Now, let me invite the last speaker of this segment, my respectful colleague, neurologist, Dr. Abdul Aziz Ashkanani. He is having a fellowship in adult neurology from the Royal College of Physicians and Surgeons of Canada, and he also holds a Canadian Society of Clinical Neurophysiologists qualification. He is presently a neurology consultant at Ahmadi Hospital, and he also attends neurology clinics in Dar al-Shifa Hospital and is involved in electroneurophysiology in the same hospital. Curiously, he is also a president of International League Against Epilepsy, Kuwait chapter. He is the from 2017, and he is actively involved in that segment also. And this is a great contribution. Your floor is open for approach to myopathy. Dr. Abdul Aziz, proceed.
Thank you, Dr. Riyad, for this gracious introduction. And thanks for the organizing committee to the invitation. And unfortunately, this is going to be a very dry topic. You're not going to be hearing the latest and most wonderful studies and somebody did that and the study showed this, but rather it's a more of a dry day-to-day clinical application of what you should have already know from myopathies. So this is the approach to myopathy, not how to diagnose a myopathy. Okay. So to start with, I'm going to give some introduction and then we'll go over a diagnostic procedure. And finally, I'm going to give some information on what to look in a patient suspected to have myopathy and how to actually reach a specific myopathic diagnosis. So first of all, muscle diseases are a heterogeneous group of disorders. They're usually characterized by muscle weakness, myalgias, exercise intolerance, and they may happen at any time or age. And they are in variable distribution and have different pathological features. The most important thing is to remember that when we think of myopathies, we also or always think of pure motor weakness, so no sensory involvement, right? And so having a sensory involvement should raise a red flag unless somebody has a different cause for their sensory features. And of course, some of the myopathies would involve other systems, such as the cardiac system, the bulbar, the paraspinal muscles, and things to look for. So how do we typically diagnose a myopathy? The most important thing is our clinical history and physical examination. This is where you need to spend most of your time, taking a proper detailed history and evaluation the clinical picture of your patient. You should have a family history. And after that, you'll go for the serological studies, electrodiagnostic studies, and the muscle biopsy and genetic studies with muscle MRIs if needed. I'm not going to go through the process, but for example, in the muscle biopsy, when we do it, we try to identify a treatable myopathy. We try to characterize the myopathy through the histopathology and potentially target a genetic intervention there. And then we also sometimes we use a muscle biopsy to interpret the genetic testing that was done prior to that. There are also certain antibodies associated with some of the myopathies that could be looked for. But again, this is not our talk today. Our talk is the approach to myopathies. Here, for example, you could see these 4 different stains for a patient with lipid storage disease. And this is what typically you see on muscle pathology or histopathology. When you request an electromyography, you could see the short polyphasic motor unit potentials compared to the normal and the large polyphasic MUPs. And you know it's large because this is a microvolt and this is a millivolt. So this is a 10 times height of this. So anyway, and this is the 200 microvolt. So this is the way you usually identify that the patient has a muscle disease. So they have a pure motor weakness, no sensory, and you have some support from the electrodiagnostic studies and maybe a muscle biopsy. You do electrodiagnostic studies to identify the muscles you need to biopsy. You do the biopsy to identify the treatment and maybe direct your serological studies. MRIs are sometimes used to identify the muscles for the biopsy or specific electrodiagnostic studies. So how do you go about when you have a patient whom you think has a myopathic process? The first thing is to determine whether the patient has what's called a negative symptoms, such as weakness, muscle atrophy, fatigue, or exercise intolerance, or if they have positive symptoms of muscle disease, the myalgias, cramps, contractures, stiffness, myoglobinuria, and muscle hypertrophy. If it's a hypertrophy, is it true hypertrophy, like in myotonia congenita, amyloidosis, sarcoidosis, hypothyroid myopathy, neoplastic process, inflammatory process, and ectopic ossification, compared to the pseudohypertrophy that is seen in this picture in a Duchenne muscular dystrophy, or in Becker, or in some of the limb girdle muscular dystrophies. So you have to identify that to identify which disease you're looking at. The other associated symptoms is the myoglobinuria. As you can see, the discoloration in the urine here in this image. And myoglobinuria not only seen in muscle diseases, but can also be seen with intensive exercise, viral and bacterial infections, drug and toxins, neuroleptic malignant syndrome, heat stroke, prolonged fever, and metabolic disturbances. And the common muscle diseases that have it are the inflammatory myopathies, metabolic myopathies, glycogenosis, lipid disorders, malignant hyperthermia, and some of the limb girdle muscular dystrophies. The other important features that we look for are contractures. And what we mean by contractures are the early contractures, because anybody with the weakness for a long time, they will develop contractures. But if they develop it early, then you think either a Bethlehem myopathy or Emery-Dreifuss. And the difference here is that with Emery-Dreifuss, you have the neck and spine contractures early on compared to the Bethlehem. Other causes of contractures, as you know, are the stroke, central nervous system demyelination, and ALS with upper motor neuron findings. The other way to look at the muscle diseases is to look at the age of onset and divide them accordingly. So if you have somebody who had myopathy from birth, then you know that you're dealing with a congenital myotonic dystrophy, central nuclear myopathy, congenital fiber disproportion, central cord disease, Niemelin myopathy, congenital muscular dystrophy, lipid storage diseases, and glycogen storage diseases. In childhood, you have the muscular dystrophy, the congenital inflammatory myopathies, lipid storage diseases, and the glycogen storage diseases, mitochondrial myopathies, and endocrine metabolic changes. The inflammatory myopathies are mostly dermatomyositis. The polymyositis are rare in childhood. So this is to keep in mind. And in adulthood, you have the muscular dystrophy, inflammatory myopathies, the metabolic myopathies, like the acid maltase deficiency, the lipid storage diseases, and the brancher enzyme deficiencies, inclusion body myositis in the inflammatory part, the thyroid dysfunction, hypo and hyperthyroid, adrenal and pituitary dysfunction, toxic myopathies, especially with medications such as corticosteroid, colchicine, and statins. Alcohol and local injections of narcotics are also causes of myopathy. If you take the family history, then you would be able to build the family tree, and based on that family tree, You would know whether the patient has an X-linked myopathy, like in the case of Duchenne, Becker, and Emery-Dreifuss, or if they have an autosomal recessive in the limb girdle muscular dystrophies, metabolic myopathies, and Becker's myotonia, whether they have autosomal dominant, and that's your FSH, limb girdle muscular dystrophy, OPMDs, myotonic dystrophy, Thompson disease, and central core myopathy. If they have a maternal transmission, then you're looking for mitochondrial myopathies with the other associated features of mitochondrial disorders. So the other features that you should look when you find a patient with myopathy is to examine their heart. You look for cardiac arrhythmias, such as that in Kearns-Sayre syndrome, Anderson syndrome, polymyositis, and myotonic dystrophy. This can also be found in some of the limb girdle muscular dystrophies, including Emery-Dreifuss. A patient could have congestive heart failure rather than the conductive abnormalities. And this is seen in Niemelin myopathy, acid maltase deficiency, polymyositis, Duchenne, Becker, myotonic dystrophy, and again, Emery-Dreifuss. If a patient has respiratory insufficiency, then you're looking for muscular dystrophies, the same ones as before, right? And if they have, or they could have inflammatory myopathies, specifically or more prominently polymyositis, mitochondrial diseases, and metabolic myopathy, acid maltase deficiency, and carnitine deficiency. And then you have your congenital myopathies. Of interest, one of the differentials for patients who are failed to wean off ventilator in the ICU, you should always keep in mind the acid maltase deficiency, in addition to your acute acquired disorders. So how do I identify which muscle disease that patient has? And here is mostly a pattern recognition. You have to have a good physical examination of your patient, and then you could reach either pattern 1, where they have a limb girdle type of weakness in the upper and lower limbs symmetrically. And here could be a subacute acquired, like in the inflammatory myopathies, endocrine myopathies, and into toxic and drug-induced myopathies. This could be chronic and hereditary. And this is your dystrophies, congenital myopathies, and mitochondrial myopathies with acid maltase deficiencies. If somebody has distal weakness, and here they would have what's called the late adult onset distal myopathy, or a early adult onset distal myopathy. These are your Nonaka Mayoshi. They could also have deep branchial deficiencies, inclusion body myositis, where you have to examine the finger flexors for the distal weakness in the upper extremities. So always not ignore the distal muscles when examining a patient for myopathy. If a patient has a scapulopironial weakness, then they have a scapulopironial dystrophy, right? So proximal arm or distal leg weakness. They could have facioscapuloperoneal dystrophy with the facial muscle involved. They may have acid maltase deficiency, central core myopathy, Emery-Dreifuss, and some of the limb girdles, specifically calpain and FKRP. The fourth pattern of weakness is the distal arm, proximal leg weakness. And here are your inclusion body myositis in the case of the acquired, and this is the common asymmetric weakness, and your myotonic dystrophies, which are uncommon but symmetric weakness on physical examination. In this pattern, the facial muscles are usually spared, and the involvement is different from one muscle to the other. Again, you have to test the finger extensors and flexors to identify the distal arm weakness. If a patient has ptosis and you think this could be a muscle disorder, then Those who have ptosis, you have to look at their extraocular movements. If they have ophthalmoplegia, then you're dealing with OPMD, oculopharyngeal myopathies, mitochondrial myopathies, Karen-Sire and CPEO. In addition, the neuromuscular disorder have to be on your mind when you examine the patient with ophthalmoplegia and ptosis. If they have no ophthalmoplegia, just the ptosis, then you're dealing with myotonic dystrophy, Distal storage myopathy, and some of the congenital myopathies like you see on this list. The sixth pattern of weakness is the neck extensor weakness. And this could be just an isolated neck extensor myopathy. And believe me, patients will not be satisfied with this diagnosis. I have a patient whom I diagnosed him with that, and then everything was done. He went abroad, confirmed their isolated neck muscle weakness for physio, came back, and after a couple of years, he comes again and say, why don't I go somewhere else? Maybe there is something else. They're still not convinced. It's very difficult to convince patients. Again, so the neck extensor weakness, the isolated neck weakness, could be part of the polymyositis or dermatomyositis, IBM, FSH, myotonic dystrophy, and congenital myopathies. The other differentials for this type of weakness, the camptocormia, as we call it, the hyperparathyroid, carnitine deficiency, myasthenia, and ALS, they all can have head drop. Parkinson patients can have head drop. So you have to be careful with that when you're dealing with patients. The seventh pattern of weakness is not an actually myopathic process, but it's put there for sake of completion for the different possible patterns of weakness we can find. And here we have a bibrachial palsy. And this is in patients with ALS, GBS, paraneoplastic, amyloid polyneuropathies, IgM-related paraproteinemia polyneuropathies, brachial neuritis, porphyria, central cord pathology, and HMPP. So hereditary neuropathy with liability to pressure pulses. So this is a slide maybe before last. And this is the patients whom you see with high CK on their lab test. It's been done as routine for whatever reason, and then they have a high CK. And you examine them, they are not weak. So what do you do? What is that? So there are many reasons for a high CK with normal physical exam or no weakness. And you're gonna see in the slide here, the congenital myopathies when they are asymptomatic, like in some of the dystrophinopathies, some of the glycogen storage diseases and Meioshi, for example, some of the metabolic myopathies. If somebody had just had their EMG tested for whatever reason, they had trauma, surgery, seizures, strenuous exercise, local injections, acute psychosis, increased muscle mass in certain race, and especially in Black males, I think, with some medications. So all these can cause a high CK when you're testing the blood. So whenever we have a high reading, we have to make sure at the timing of the blood sample, was it related to any of those activities? And we have to look at the patient's race, gender, their muscle bulk also. In addition, and after all that, they may all have asymptomatic myopathy, and that's why we're seeing it, or just primary hyperCKemia with nothing else with it. And we just keep observing and do nothing as long as they are stable on whatever level. So to summarize, the approach to muscle disease is very broad topic. You have to have a proper history and physical examination to guide you to narrowing your differential diagnosis and guide your diagnostic process. You have to look for associated symptoms, not only to identify the disease, but to prevent some complications, especially with the cardiac disorders. You have to recognize the most common patterns of weakness to help you with this effort. And remember that high CK is not only seen in patients with muscle disease, but has a wide differentials that we have to keep an open mind for. Thank you.
Thank you, Dr. Abdul Aziz. As you predicted, it was not dry subject at all. It was most enjoyable. And now I will direct